everyone, and welcome to this special Black History Month conference hosted by MS Focus, the Multiple Sclerosis Foundation, made possible with support from Biogen, EMD Serono, Genentech, and Bristol Myers Squibb. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and today our speaker is Tirisham Gyang, whose topic is People of Color with MS and Research. After the presentation, we will open it up for your questions and comments. Dr. Tirisham Gyang is a neurologist specialized in treating multiple sclerosis, demyelinating diseases, and autoimmune disorders of the central nervous system at the Ohio State University College of Medicine, where she also serves as the program director of the Multiple Sclerosis Fellowship. She has served as the principal investigator in multiple clinical trials and research studies. She believes in providing customized, comprehensive, interdisciplinary care, giving patients the tools they need to thrive and maintain their quality of life. Dr. Gyang is a National MS Society Scholar and a member of the American Academy of Neurology. We're pleased to have her join us to present this important topic. And as soon as I finish sharing the screen, Dr. Gyang, I'm going to turn it over to you.
Okay, can you hear me and can you see my slides?
Yes, we can.
Good. Let's make it a slideshow. Okay. So I'm really excited to be presenting to you all this afternoon. Thanks for the introduction. And I'm excited to be working with the MS Foundation on this. My screen is a little big, so I'm trying to figure out how to make it smaller without, oops. It's okay. I'm just gonna leave it as it is, but it may be a little problematic, but it should be fine. So I'm excited to present to you today. I am currently at Columbus at Ohio State University. And as she said, I'm an MS specialist, and I work with patients. I do a little bit of research, and I also do medical education, training other doctors to become MS doctors. These are my disclosures. Let's make this small. Okay, perfect. These are my disclosures. So I've had personal compensation from EMD Serono and Genentech, none of which is going to affect this presentation. All right, so this is an outline of what we're going to cover. There's a brief introduction about MS, and then I'm going to focus on MS in underrepresented populations. So basically, we're talking about research in people of color, and people of color from my standpoint would be underrepresented populations, Hispanic and African American populations. I will talk about clinical trials in MS or clinical research in MS and barriers to clinical research and why we want more people to get involved in clinical research. So just a little bit of introduction about MS. I'm sure a lot of us know something about MS, and that's why we're here. So, and I'll try to simplify this because I know this is a lot of non-medical people on the call, but MS is the most common inflammatory demyelinating disorder that affects the central nervous system. So basically, we're talking about the brain, the spinal cord, and the optic nerves. Of all the inflammatory demyelinating disorders, MS is the most common one. And then the other thing is the disability in young people. So it's the second cause of disability in young people. The first cause of disability in young people is trauma. So whether it's an accident, a fall, some kind of trauma. MS is the second when we think about our young people. There are different types of MS. There's a relapse and remitting MS, which is the most common type of MS where, patients have relapses followed by remission. And then there's a secondary progressive type of MS where the patient starts with relapses in the beginning and then have a slow progression in disability at some point. At this point that they have that slow progression, we classify it as a secondary progressive phase. Sometimes there may be relapses during that slow progression of disability, and that's called active secondary progressive MS. And then we have the third one here, which is not as common as the other two. So primary progressive MS, where you have a slow progression and disability from onset. So there's no relapses, there's no, attacks that come and go. It's basically a slow progression of disability that starts from the get-go. So a little bit more about MS. The relapse and remitting type of MS is more common in women. So 3-to-1, women versus men. Um, Primary progressive MS is a little bit more evenly distributed between men and women. So it's about 1.2 to 1 in ratio between men and women. And then at what age are you most likely to be diagnosed with MS? For relapse and remitting MS, somewhere in your 30s, the mean age of onset is in the 30s. Um, for primary progressive MS is about 10 years later. So 40s to 50s is generally when we see the symptoms of MS starting for primary progressive MS. A lot of patients ask about, is this a genetic disorder? Is this something I got from my parent? Is this something I can give to my children? Um, yes and no. So it's not an inheritable disorder as we think about, certain disorders that you can either, there's a 50-50, sometimes we say, of getting it from a parent or, a family member. But there is a genetic susceptibility. So if you have a relative with MS or first degree relative with MS, your risk of MS goes up 20 to 40 fold compared to someone without a direct family history of MS. And the most common genetic haplotype that has been identified as given a risk for MS is this HLA-DRB1. That is one of the genes that has been identified, but there's multiple others that have been identified to increase the risk of MS. And then just a little bit about, when we look at monozygotic twins, so if we look at identical twins, there's a 30% chance of both of them, if one has MS, the other one getting MS. If it's a dizygotic twin, it's a 5% chance if one person has MS for the other to have MS. So that tells us there is some degree of genetic predisposition, but it's not 100% genetics. There's other things that factor. And another question we get a lot is what causes MS? People ask me, like, what did I do wrong? Did I eat something wrong? What exactly, why did this happen? So we don't have a clear answer of what causes MS, but it's a combination of genetics, immune dysregulation. So for some reason, the immune profile gets dysregulated. And then there have been some environmental factors that have been identified as increasing the risk for MS. There's some viruses, we talk about low vitamin D level, smoking, high salt diet has been identified as a risk factor. So there's a lot of different things that come together. One of my teachers used to say, it's just think about a perfect storm. Everything from the genetic side, from the environment side, and then some dysfunction in the immune regulation all happen together. And that's how, a lot of autoimmune diseases come about. How do we diagnose MS? I'm sure a lot of us have gone through this process. First of all, there are symptoms that are suggestive for MS. So that could be losing your vision, weakness, numbness, tingling. There's a variety of symptoms that can come up. And then we always have to look at the MRI scan. So basically, we're looking for these scars on the MRI scan. You can see examples here. They can be in the brain, they can be in the spinal cord. We are able to identify, we call them lesions on the brain or the spinal cord, sometimes in the optic nerves. And then sometimes we get additional tests. For instance, a spinal tap. Not everybody has to get a spinal tap, but sometimes a spinal tap can be helpful. And there are other tests called evoked potential tests that can be done to help in coming up with that diagnosis. What are the symptoms that can come as a result of MS? So there's a lot of symptoms. This is a word cloud, from patients with MS. As you can see, the most commonly reported symptom is fatigue, but a lot of other symptoms like pain, headaches, cognitive dysfunction, walking difficulties, paralysis. So there's just a wide range of symptoms that MS patients can exhibit. Okay, so we're getting a little bit closer to, our main topic of discussion. So what is the prevalence of MS in the US? Meaning, how common is MS in the US population? So there was a study in 2019 that tried to answer this question. The study was published in 2019. Prior to the study, we all thought there were about 400,000 people with MS in the US. That was a number we had used for a long time. That was what we thought, was the prevalence. But this study showed us that there's almost 1 million people with MS in the US. So it's almost twice, or it's more than twice of what we think it is. And so there's a lot of MS is a significant problem in the US. We have a lot of young people in the productive parts of their lives that are affected with MS. And then this picture just breaks it down into the prevalence of MS in the different parts of the US. So the highest prevalence is in the Northeast, up here at 377 per 100,000, followed by the Midwest. And then the West and the South are about the same. And so we see this gradient of, more MS up north than in the South, which is what has traditionally been reported. How about prevalence of MS in the world? So, we don't have data from a lot of countries, but we know that MS is most prevalent in countries that are further away from the equator. So, in the US, we usually talk about a gradient that the risk of MS goes up as you go up north. We also have a significant risk in Europe and in the UK. There is also a significant risk in age. As you come closer to the equator, basically, it's believed that that risk of MS gets lower. But then as you go further away from it, if you look at Australia, we see that that risk starts to pick up again. Okay, so let's talk about MS in underrepresented populations. So we're talking about African Americans, Hispanics that are, underrepresented in the US population. How does MS affect these groups? So in general, MS has been reported in in most ethnic groups. So in the past, what we learned in school was that MS is a disease of Caucasian women. And that was the typical presentation. If there was a question about MS, it would always be a Caucasian woman that's young in that question. So the prevalence is highest in Caucasians of Northern European ancestry. However, the incidence, and incidence means how the yearly new cases that you have of a disease. The incidence is growing in ethnic minorities, and I'll show a few studies that have looked at this. So African Americans, Hispanics have a higher risk of MS today than what is in their ancestral countries. So for instance, an African American in the US generally has a higher risk of MS than an African in Africa. That risk is higher, and the risk is higher than we thought. So in the past, I've met a lot of patients that just said, nobody thought it was MS because, I was an African American or because I was Hispanic, and nobody just thought, oh, this could be MS. But so the risk is actually much higher than we have thought in the African American and Hispanic population. So I'm going to talk about two studies here, and I'm going to try to explain the graphs. There were two studies to try to understand the incidence of MS in minority populations. The first one up here is a study, is a Kaiser Permanente group that looked at cases of MS between 2008 to 2010. And it broke it down into different demographic groups. So we have whites, African American, Hispanic, and Asians. Asians and Native Americans. And if you look at the incidence meaning how many people were newly diagnosed with MS within these years. In whites, it was 6.9. It was actually highest in African Americans, it was 10.2. 2.9 in Hispanics, and then 1.4 in Asians. And there was another study that looked at, the US military veteran population, and it covered a wide range of time, so between 1990 to 2007. And the findings were very similar, where African Americans had the highest incidence of MS, meaning newly diagnosed cases, followed by whites, followed by Hispanics, and then we have Asians and Native Americans. Now, this graph is from the first study, and you can clearly see that when you break it down into males and females, we talked about females having a higher risk of MS than males, especially the relapsing remitting type. But you can clearly see that Black people have the highest incidence, at least both males and females that we can see here. That's followed by, white females, and then Hispanic females a little bit below Black men and white men. So this is it's changing the way we think about MS. We've always thought about MS as this is a disease that affects Caucasian women more likely than men. But we're seeing that the incidence is increasing and is much higher than we thought in ethnic minority groups. So there's a lot of questions come up when we see this data. So some of the questions are, are there differences in the way MS presents based on the demographic group that you're in? So if you're, white versus African American versus Asian versus Hispanic, is there a difference in the way that MS may manifest in you? Does your race or ethnicity affect long-term outcomes? How does your ethnicity play a role over a long time if you have MS? And then are there certain treatments that are more effective in specific groups than others? And the way that we answer questions in medical science is research. So we design studies based on questions that we have. If there's a specific question, we try to design a study to try to answer that question. So let's talk about, MS research in minority populations. And I'm getting this information. There's an article that was published several years ago by a few MS experts. And they looked at, let's just look at literature. How much papers have been produced about, or how much papers have been written about MS in minority ethnic groups. So overall, there were about 52,000 papers that were in English in a PubMed search in 2014. And of these 52,000 papers, only 113 focused on African Americans with MS, and only 23 focused on Hispanic Americans with MS. So this gives us an idea of how much research is going on within these groups, because a lot of times research is disseminated by publishing these articles. So it shows us that there's not a lot of research that's going on. And we talked about that high incidence where more people are getting MS, but we haven't really studied and tried to figure out what's going on. And, are there any specific concerns within specific demographic groups that we should know about in terms of MS? And this is another study that was published a few years ago that looked at clinical trials. So clinical trials are the way that we test new compounds or new drugs to see if they are effective for MS or for any disorder. So clinical trials are, we do a lot of clinical trials to try to determine if a drug is effective for a disorder. And if we look at the clinical trials for the MS medications, we see that there's an underrepresentation of ethnic minorities. So African American range from 2.3 to 16%. Hispanics were about 7% in these trials. So it was consistent that there was an underrepresentation of ethnic minorities in clinical trials. And underrepresentation meaning, there were more percentages of them with MS in that group than were represented in the trial. And that usually raises a lot of concern, which we're going to talk about, in a few slides down. And so I'm just bringing up some of the data that we have now. What type of data do we have about MS? Let's start with the Hispanic population. So if we compare Hispanic MS patients versus Caucasian MS patients, and this is from the data that we have so far, Hispanic patients have a younger age of onset. So they're usually diagnosed earlier than their Caucasian counterparts. They have a higher frequency of optic neuritis and transverse myelitis. This is inflammation in the optic nerves and inflammation in the spinal cord. So there's a higher incidence from what we've seen in patients of Hispanic origin. They're more likely to have a rapid disability accumulation. So the progression tends to be more rapid in the Hispanic population, and they're more likely to have a lower vitamin D level. Now we talked a little bit about vitamin D. Low vitamin D levels are associated with a risk of MS, with a higher risk of MS. And patients with MS that have low vitamin D levels typically don't do as good as patients with, normal vitamin D levels or good vitamin D levels. So how about African American population? What do we know from the research so far? So the same thing that we saw with Hispanics, African Americans tend to have a younger age of onset than Caucasians. And then it's clear we've had multiple studies that have shown us that the course of MS is more aggressive in African American patients. For instance, they have more severe walking difficulties than Caucasians. They have more severe optic neuritis, and the recovery from optic neuritis is usually not as good as when we compare to other demographic groups. More frequent MS relapses, faster transition from a relapsing remitting MS to a secondary progressive MS. The rate of atrophy, or when we talk about shrinkage, so we sometimes have loss of volume in the brain or even in the optic nerves that we can quantify. What has been seen is that rate is much higher in African American community patients with MS than their counterparts. Now, how about the disability from MS? Is there a difference between demographic groups in how disabled people are from MS? And the answer is yes. African Americans are more likely to be more disabled than Caucasians. So there's an article that was published in 2010, and this is a disability scale, the MS severity scale that was used to quantify how disabled people were. And it was clear that when you look at the lighter disability scale, so if you look at 1, 2, and 3, which is a smaller disability scale, you have more white Americans. So the green is white American. You see that those numbers are higher, meaning the disability is more, the lower disability rates have higher white Americans. But then when you look at more disability, meaning higher disability scores, African Americans are more likely to be disabled, when you look at these two groups. And when we break it down into benign versus malignant, benign meaning they're not as disabled, malignant meaning they're very disabled, you can clearly see that more white Americans had benign numbers, more African Americans had malignant numbers, meaning there was a higher proportion of disability, high disability in African American groups. And then how about death? Like, how do patients with MS die? So this study looked at the MS mortality by race in US women. So this covered between 1999 to 2015, and we're looking at mortality. So, at what age are MS patients dying? And when we look at this, all these, they look very similar. These graphs look very similar. However, if you look at the blue line, in the African American community, the mortality is much higher at a younger age. And then at about 50, 55, that plateaus a little bit and the Caucasian mortality goes up. So what we can infer from this study is that the mortality is higher in African Americans at a younger age. So African Americans are dying younger with MS compared to other Caucasians or other demographic groups. And then the other thing that we always want to think about is, socioeconomic factors and health disparities. And basically what this means is that what are other factors that could play a role into a person's health, other than, your genetics or your biology. So health disparities exist in the society. Socioeconomic, the society is broken into different socioeconomic groups. From the research we have, we know African American and Hispanic groups are overrepresented in populations that are disadvantaged by poverty or lower socioeconomic status. We also know that these groups may face more barriers to accessing quality care. They're less likely to have access to rehabilitation services, mental health services, or even MS subspecialty services. And that always brings a question of social determinants of care. What are those barriers that people may have? If you're working 3 jobs and you're trying to keep up, you have to work so many jobs, then it's more difficult for you to find time to go to a doctor's appointment. If you live in a part of town that has no transportation, then you're less likely to go to a doctor's appointment. So there's a lot of other factors that play into how the disease, plays between different populations. And could there be a socioeconomic factor? Possibly, possibly. So just to summarize what we just talked about, ethnic minorities, so African Americans and Hispanic Americans, have a higher risk of greater MS disease burden. That's what a lot of research has shown us. There's an earlier onset of disability in these groups. We saw that the mortality is higher in the earlier ages in the African American group, these groups are at higher risk of not having the right access to care. And then when we look at research, there's an underrepresentation of ethnic minorities in research. And so, we have a lot of questions, but yet there's not a lot of research to answer those questions. As we said, socioeconomic factors may influence some of these outcomes that we're seeing. But overall, I think we all agree that more research is needed, more studies, more questions, more answers are needed to the questions we have. And the way that we answer these questions is by clinical research. So let's talk a little bit about clinical research in MS. And basically, I want to cover why do we need more African Americans? Why do we need more Hispanics? Why do we want diversity when we are recruiting patients for clinical research? Is there a big difference? Is there a need to have different types of people when you're doing research? And the answer is yes. And I'm saying that as a researcher because I have I've been the PI on a few different studies. So basically, a lot of research, the way that a lot of research is done, I'll just give an example is, let's say you have a group of people here, this big group of people with MS. What you do is you take a sample out of this group. So you take a few people out of this big sample. This big sample represents everybody with MS. So you're picking a few people and you do your research on a few people. But you hope that the few people you picked, the result of the research can explain to you what's going on in this big group of people. And so the sample that you get should be a good reflection of the population with the disease. So, an example I always give patients is if we had a drug to test and we selected a sample of all men and we tested this drug and it worked really well in all men, we can't really say everybody in the society can use it because we don't know how women are going to react to that drug. And it's the same thing we have in terms of, the different demographic groups. What if the safety or the effectiveness of an MS drug is different in certain demographic groups? If we don't have as many of that group represented in the sample of people that we are researching, then it doesn't give us a good idea of how this whole group is going to respond to the medication. And the other thing is, the disease may be a little bit different from one demographic group from another. As we said, we've seen a lot of points about how MS may be different or may present differently, whether you're Caucasian, African American, or Hispanic. Now, if you're doing a study and the study only has one group of people, then you can't really generalize the outcome of that trial to everybody. And that is why we need more diversity in clinical trials, because we need to understand how an intervention affects, people of a diverse population. And we also want to know over a long time, how does MS behave in one demographic group from another? And so that brings us to a term called generalizability. It's a big word, but basically it means if you select a sample of people and you do a research study and you get your result on this sample, how well does this result give you an idea of what's going on in the true population of patients with that disease? So to what extent do the result obtained from a sample, to what extent can that result be applied to the whole population? in order to increase this generalizability, you need a very diverse sample group. You need all sorts of people in that sample. You need people of different races, you need people of different genders, so you need males, you need females, maybe you need people that wear glasses and people that don't. You just need, the more diverse that group is and the closer that group is to your true population, the better the results will translate to everybody else. So just a few examples of what we have found. For example, there are some studies that have shown that interferon, so one of the treatments for MS, interferon therapy, is less effective in African Americans compared to Caucasians. And this was done in what we called a post hoc analysis. So when you do a big research study, you look at everybody that, you compare two different groups, people that got a medication versus people that didn't. But then you can break down your result into smaller groups and look at those smaller groups. And for instance, when we looked at this smaller group in this study, we found that a greater proportion of African Americans had more. So African Americans had more relapses compared to white people in this study. Another factor that we've heard is that high efficacy therapies, so if therapies that are very effective, seem to have very good outcomes in African American population. But because there's so few of African Americans in these trials, we can't really make a lot out of this finding that we see in some clinical trials. And so if you don't have many people represented that are African American or Hispanic or Asian in that study, it makes it a little difficult to generalize that result to say, oh, I found this in the study, therefore, this treatment would be better than this treatment for people that are from this demographic group. And this is another example. So this is a study, I think was done at Johns Hopkins. Just a different, that this is not a clinical trial, just to show you another type of study that was done. So in this study, they looked at 22 African Americans and they matched them with 60 Caucasian Americans. So you find a patient, a group that you want to investigate, and you look at a matched, group that's in a different demographic. And, African Americans had, more pathology in their optic, in their retina. On the MRI, they had greater rates of atrophy. In your OCT, which is a test that looks at the retina, they had greater rates of atrophy. Atrophy means shrinkage, than their Caucasian counterparts. So in a study like this, you have a group that you want to understand, and then you compare it with another group. And there's clear differences that we see between the way that MS presents in one group versus the way that it presents in another group. And so that brings us to, research in MS. So what types of research what are the types of research that's available for patients with MS? Because a lot of times we talk about the importance of research and people say, well, I have no idea, like how do I get involved in research? Who do I talk to? So I'll talk a little bit about the different types of research that you can be involved in and how, that we've seen how helpful it is to have, a very heterogeneous group of people in the sample, meaning a diverse group of people in the sample. But what are the types of research that you can be involved in? So we have clinical trials. Usually these are big studies, that are done at a very big scale. They typically start with a phase 1. So there are different phases in a clinical trial. So the clinical trial basically answers a question, is this intervention, for instance, is this medication effective in MS? there's a long process. It takes years before that happens. First of all, it starts in the lab, or, we talk of preclinical. So before we even give it to human beings, it's tested in the lab. Sometimes it's tested in animals, and we see that maybe there's a potential. After that, we go to different phases of studies. There's a phase 1, there's a phase 2, there's a phase 3. The phase 3 is usually the big study. And, it has to have passed all these stages before it gets to a phase 3, because the FDA is going to look very thoroughly at the phase 3. And if the phase 3 did really well, then the drug will be approved by the FDA, and it becomes a drug that we can prescribe for patients with MS. So as we said, if in this phase 3, which we talked about, there's an underrepresentation of Hispanics or African Americans, how well can that result translate to the bigger population, or, all patients that have MS? It may or may not. If you don't have enough of a specific demographic, you may not pick up something that could be a concern in that demographic. It may not be generalizable if you don't have a diverse sample size. And then there's another type of study that, I've been involved in both types of studies. So this is what we call a registry study. So a registry study is more of an observational study. So basically, we're collecting data from MS patients. There's no intervention, meaning we're not giving you a drug, we're not, giving you an intervention, but we just take a group of MS patients and we study them over a long time. And that gives us a lot of information about, maybe how MS progresses over the years, how patients with MS, how disability, progresses from one stage to another, how patients on specific treatments maybe progress versus people that are not treated. So it's an observational study. We're just studying MS patients to try to understand MS better. And I've put a few examples, both of which I've been a part of. The NACRM study from the CMSC is an MS registry study. So basically, your doctor, if you're enrolled in the study, just provides data about how you're doing over a long time. And when we analyze this data, it helps us to understand how patients with MS evolve over time. Another one is the COVIMS study. This is a study of patients with MS that were infected with coronavirus. I have contributed data to this database. So basically, we're just looking at, patients with MS that had COVID. How did they do? What were the outcomes? Did they recover? What of the patients on specific medications? How did they do versus people on other medications? So that's more of a registry. We're looking at a cohort of people and we're trying to understand, how MS evolves or how COVID affects MS. Now, it's the same deal with the interventional studies. If, for instance, all the patients in this sample were of one demographic group, we don't know how MS and COVID would affect a different demographic group. So we want diversity. We want to have different people from different demographics. We want men, we want women. We just want a lot of diversity in those sample sizes. Now, what are some of the barriers that can affect research? So barriers meaning what are things that could hinder us or hinder people from participating in research? Mistrust of medical community. And there are reasons for this that I'm going to talk about. Sometimes it's a misinformation or lack of information about research. And sometimes it's, poor recruitment. If a study is being conducted and, it's in a part of town that is very homogeneous, it's difficult for people from other parts of the town or other parts of the city to come to that trial. And then there are personal factors like religious beliefs or socioeconomic status. If you have a patient that, has multiple, that plays multiple roles and, has multiple jobs, it may be hard for them to do research. So there's a lot of factors that come into this. I always want to talk about, why do people mistrust research, the research community, or, sometimes the medical community in general. So it's not unfounded. There have been things that were done in the past that have made people very skeptical of research. For instance, the Tuskegee syphilis study. In this study, treatment was withheld from African American men with syphilis even after the treatment for syphilis was discovered. We have the Willowbrook hepatitis study, where this children, it was a house for children with mental disabilities. These children were infected with hepatitis to see how the virus evolved. And many years ago, we talked about the Nazi experiments. How people were used in experiments that were very unethical. So sometimes the mistrust people have is founded in things that happened a long time ago. And a lot of times patients bring this up to me. And what I tell every people now is there's been a lot of changes that have come up because of all of these unethical research practices that happened in the past. So right now, the Belmont report is so anyone that's doing any kind of clinical research on people has to go through extensive training in learning how to ethically conduct research. And so, the three principles are respect for persons, beneficence, and justice. And I just talked a little bit about what each of them says. So basically, we have to respect your autonomy. We can't force anyone to do research. You have to be informed of what the research is about. You have to be able to understand that research, and you have to willingly, enroll for that research. We have to maximize the benefits and minimize the risks. And then justice means we can't exploit people. You can't exploit a specific group because of a position they're in. For instance, if somebody is less privileged or handicapped in some way, you can't exploit that to use them to get into a research study. So a lot has changed, and research is not what it was years and years ago. There's a lot of oversight. Before any kind of research is done, most institutions have to submit what we call an IRB application. It's called the Institutional Review Board. Your study has to pass through many channels. They have to look to see if there's any issues, there's any ethical issues that's wrong with that trial before you can even start recruiting patients for it. We have to consent patients. We have to make sure that the patient understands what, there's a lot of oversight that, is that surrounds research. So for people that are still skeptical, ask questions, talk to your doctor if you are considering a research study. I always tell patients, ask as many questions as you can. And, don't, if you have fears or concerns about research, the answer is look for an answer to that rather than just say, I'm never going to do research because, I'm not sure what they're going to do with me. And then if you want to get involved in research, so people, if you have interest in getting into research, how do you do that? You can start with asking your neurologist about research opportunities. You can ask in a comprehensive MS center. So most comprehensive MS centers usually have some kind of research study going on. We have a few, we have several research projects that go on, and we're always recruiting for one study or another. So most comprehensive MS centers have that. And then I always emphasize to talk about your concerns. Talk about, people always have certain, so for instance, people say, well, I don't want to be a guinea pig. or, I think I want more people to get this before I do. So if you have any concerns, just bring them out. Don't be afraid of talking about those because, sometimes, there are things that are not true that are portrayed as being true about research. As I said, there's no concept of being a guinea pig. Like we never have a drug that has never been tested for safety and just, give it to people. A lot of times it goes through multiple steps before it gets to a point that, we're actually doing research on it. And then there's a lot of websites that you can get information about research. Clinicaltrials.gov gives you information about clinical trials. The National MS Society, so they actually sponsor a lot of MS research. And, on their website, you can find information about research that they sponsor, and you can find information about where to get, where to be enrolled if you're interested in that study. And then there's also this website called researchmatch.org. So I actually just found out about this recently. If you go on that website, you can provide some of your information and they will be able to match you with research that you may be able to enroll for. So you give them maybe your age, your demographic, your disorder. It's not just for MS, it's for any kind of disorder. You give that information in, and then it gives you a match of things that you may be able to do. And so that's another resource for people that are interested in doing research and are just looking for what's out there. So this is the end of the presentation, but this is just a summary of what we talked about. So we said, the incidence of MS is growing, in African American and Hispanic groups, or, ethnic minority groups. And then there may be a difference in the way MS presents between one demographic group and another. So we saw that, African American groups had a more aggressive course most of the time, than their Caucasian counterparts. And then we also learned that, there's an underrepresentation of ethnic minorities in clinical research. So we have questions about, how MS plays in certain groups, but then, we don't have a lot of research involvement, and so we don't have answers to those questions. And then finally, what we've been talking about is that we need more diverse representation in research. We need more people of different ethnicities to, be involved in research so that we can answer questions. We can answer questions that we have regarding MS and how it plays out in different groups and in different people. So this is the end of the presentation. Thank you for listening and for paying attention. And I think we have some time for questions. So I will put this back to the moderator and just say if there are questions. I'm not sure if we're writing down the questions or people can ask questions.
Yeah, so first of all, thank you, Dr. Gyang, for sharing this information with us. To everyone watching, there are two ways to ask questions. You can either type them into the chat box or use the raise hand feature in the app. If you are watching this from a computer, you'll find the raise hand feature in the participants window if you'd like to speak directly to Dr. Gyang. And if you are on a mobile device and you have a question and you would like to raise your hand, you would click the screen to pull up the menu and select more, which is the icon with 3 dots. And you'll ask if you'd like to be unmuted, and you would give me permission to do so. So while everyone who is interested in asking questions is trying to find the features, there is someone named Tina that emailed us a question a few days ago. So she says that she's had MS for 24 years and she was initially diagnosed with relapsing remitting and since her symptoms have progressed. And if there was any research or trials done on people that have more progressive forms of the disease, and if so, were they African American?
Yes, so there are studies that are now looking at MS, progressive MS, as opposed to so relapsing remitting MS is the more common type of MS, and there's more treatment options. We have a huge lack of medications for progressive MS types. And there are actually studies that are looking specifically at progressive MS, whether it's secondary progressive MS or primary progressive MS. And so there are opportunities, I am not sure, where she's from, but she could start with asking, the neurologist or find an MS center. For instance, in our institution, we're about to start a study that's looking at a new drug for primary progressive MS and secondary progressive MS with activity. So there's a lot of research going on. There isn't one that has looked specifically at African Americans with secondary progressive MS. In general, we do big phase 3 trials, but we want to have African Americans and Hispanics, and we want everybody represented in that group so that if there is a difference between one group to another, we are able to see that from the data of that study.
So we do have a question from David. He's raising his hand. I'm going to unmute you, David, and you can speak directly to Dr. Gyang.
Hi, good afternoon. I am from the Bahamas. I have a comment and a question.
Sure.
Great presentation. And I am from the Bahamas, as I said, and I was diagnosed at the age of 14 and in 1997. So it's been 24 years. But those same things that the Caucasian females have it, those are the same research from back then, and they are still present today. Are there more data that for MS, or is MS still a phenomenon for everyone?
So is there more data now than we had before?
Yeah, than what they had before.
Yes. So I mean, there's always a variety of studies going on MS and how it affects different people. So, a lot of the data was what I presented today, in terms of we're thinking about African American groups. We have gotten a lot of data that those people in those groups tend to have a more rapid progression.
Yes.
And so basically that gives us a lot of information for how to treat patients. So if I have a patient that is African American and that I see getting more and more disabled, I would more likely choose a very effective drug because the drugs have different degrees of effectiveness.
Yeah.
So even if there is a drug that's a little bit risky, but it's more effective, I'm more likely to choose that effective drug than to choose a different drug. And so there is always data that's coming out. But the thing is, if we don't have people participated in research, then we don't have, the quality of the data depends on the diversity of people we have in the research studies.
I thank you. But then in regards to the COVID-19, is there a particular medication vaccine that MSers research that is good for the MSers to take, or there's not?
So you mean medications for COVID or MS medication?
Yeah, for COVID, because the vaccine that they're coming out with, which medication is best for MSers to take?
I see. Which MS, are you talking about MS medication or COVID medication?
COVID medication, COVID vaccine.
Good question. So COVID vaccine in MS, the COVID vaccine is a brand new vaccine. It's an mRNA vaccine. We haven't had a lot of experience with mRNA vaccines. What I tell my patients is, the MS Society has released guidelines on, the COVID vaccine for MS patients. And basically, they are recommending that patients with MS strongly consider taking the vaccine. Um, that is an ongoing discussion you can have with your neurologist. Based on the medication that you're on, your response to that vaccine may be reduced. So there are some medications that may reduce your ability to respond to vaccinations in general, not just the COVID vaccine. It's going to affect your response to any kind of vaccination you get. So if you are on a medication like that, have a discussion with your doctor and figure out when is the best time for you to get the COVID vaccine.
Thank you.
You're welcome.
We have a comment from Mildred in the chat. She said she was diagnosed with MS in 1983. At the time, she was 34. Now she's 72. And she says the textbooks used to say that Black people did not get MS. And she says she's just happy to see their focus is on African Americans now. And I actually do have a question of my own. I think that it ties into what Mildred said. It's kind of odd, though, that people of color, specifically African Americans, were thought to be unaffected by MS, and now we not only get it, or some of us not only get it, but it progresses far more than your non-Black counterparts. Is there a specific reason why, or is that unknown as well?
So we still really don't know. There's a few theories about, many years ago, there was a lot of mixing of genetics between genetics from African ancestry with European ancestry. Could that be a factor in people now getting more severe course of disease than others? In Africa, MS is not a common disease. So it's the incidence of MS or the prevalence of MS, at least from what we understand now in Africa, is very low. But then how come, African Americans in the US or in Europe or in, the UK, that risk is increasing. And we see that the outcomes of the disease are more severe in those subgroups. I don't think we have a good answer to that question. And, it all boils down to just more research needed to better understand these questions.
I actually do have another question. I'm sorry. You mentioned Asians earlier, and technically they are considered people of color too. And is there much research on them with MS, or are they more than likely to get NMO? And what are the differences?
So that's a very good question about, people of Asian ancestry. So there's another disease, you mentioned NMO. So for everybody else, there's another disease that is similar to MS called NMO, neuromyelitis optica. And that tends to be more common in Asians and people of African ancestry. So in the past, before we knew that NMO and MS were two different disorders, a lot of NMO patients were diagnosed as MS. And so, now we're finding out that they're actually two separate diseases. So NMO has a higher prevalence in Asia and Africa, or people from that ancestry, but Asians can get MS. I've had many patients from an Asian background that have had MS. We don't have as much data as well in those subgroups because it's not as common, but it's a disease that can exist in it. MS has been reported in almost every ethnic or racial group so far.
Gotcha.
I think there's another question. I can't see her name, but she's waving. Can you?
I don't see anyone waving. What's her name?
Let me see if I can unmute. Ask to unmute. Uh,
Hello?
Oh, Linda, there you go.
Linda, okay, there you go.
Okay. I have had MS for 26 years. When I started, it took me 20 years to get a diagnosis because I didn't have I had symptoms, but the tests could not pick up what I had. It took time. My doctor found a great doctor at the University of Chicago, which is a teaching hospital, which also does clinical trials.
Mhm.
But when I first started this back in 93, 94, I said, I don't want to be a guinea pig, you know, because when you're in a double blind, being a nurse, you don't know who's taking the proper medication. I would have hated to be one of those clients who had MS and was getting a placebo and then missed all the time that I needed to be treated.
Mhm.
So from the get go, I said, no, I don't want to be a guinea pig. Put me on what you need to put me on. And at the time, we didn't have many medications in Nigeria. We just had beta seron.
Mhm.
I'm sure there was Capoxin also at that time, but I injected beta seron until my skin started breaking down.
Mhm.
And then the next thing that was available was Gilenia. And
Mhm.
I've been on Gilenia ever since, and I love it. I have had no side effects. It's just the easiest medication to take because it's a pill. But how do you know when you look at clinical trials
Mhm.
and you talk about how we need to be represented in those clinical trials? I mean, there's nothing that says we need Black people. You know, there's nothing that gives you information on um, when the clinical trial is spelled out. There's nothing that says we're the person we're looking for you in specific. So I considered signing up for clinical trials, but there was really nothing that said, okay, this is going to benefit you.
Yeah.
I'm like, and because of the changes, thank God there have been changes over the syphilis and over the other things that medicine has done
Mhm.
to unsuspecting people.
Mhm.
So I'm going to continue to try now that I've heard that there are now better ways of keeping it straight, that you're not going to be mistreated and not going to be used. But I just say, like I said, there's nothing to indicate that this by this trial, we will get that information for the Black population. There is nothing that really says that.
Yeah, I mean, I don't know that we talk
Spell
more
it out.
specifically that way,
Right.
but I totally understand your points. And you made an informed decision
Yeah.
years ago, meaning they explained the trial to you, and you didn't want a possibility of being in a placebo group. And that is totally fine. In the end, clinical trials are voluntary. And when I hear patients say no, I want to make sure they understand what the trial is all about,
Yes.
and they're saying no because they have a good reason to say no versus I just don't want to think about this, or I don't do this at all. So yes, we do have trials. Every trial has a different structure.
Okay.
These days, because there are so many new MS drugs,
Mhm.
we don't typically use placebo as often.
Okay.
And for everybody, placebo means, some people get the real drug and some people just get a tablet that doesn't really have an active agent. Most MS trials these days will compare the drug they're investigating with a comparable FDA approved MS treatment.
Okay. All
And
right.
those are all questions you should ask the doctor
Yes.
before you sign up for research.
Over
If
over the years, he has convinced me to do little things. So I did donate. He said, "Can I get some blood from you?" I said, "Sure, no problem." He walks in with 17 tubes. And I'm like, "That's a lot of blood." I'm like, "Who am I supplying all this blood for?" But that's what every time I said yes, I end up getting something so unexpected. I got checked for Sjogren's, and they took the glands off from under my tongue. It took so long for my mouth to heal. I'm like, "I'm never giving you anything else because every time I end up getting something unexpected." He says, "Well, you're helping research."
Yeah, and that's the thing. You always want to ask about what are the potential risks to this study,
Yes.
and what are the potential benefits to the study, and that's why we never pressure people, and we're not even allowed to do that. We can't pressure you into going into research, but we all want people to know that it gives us a lot of information when we have a diverse representation in research studies.
Okay. Thank you so very much.
Thank you for your comments.
It's great. It was the information was fantastic. I really appreciate it.
Good. I'm glad.
Dr. Gyang, it looks like I have one more comment here in the chat from Mildred, and she wanted to know about the map that you showed earlier and if it was based on present location or where you, I guess, were originally from. So it's based on present location, correct?
Yeah, so that's a good question. The map is based on present location. So basically, your risk for MS is determined by where you spend the first 15 years of your life. So if you spend the first 15 years of your life in a part of the world that has a high risk for MS, your risk remains the same as that location, regardless of where you move to.
Wow.
Yeah. Good question.
I think that's all the time that we have for now. We did answer everybody's questions and we addressed all the comments, which is always good and great discussion. So thank you all for your participation. If you did miss any part of this conference, it will be replayed on MS Focus SoundCloud, msfocusradio.org, and on the Multiple Sclerosis Foundation YouTube channel. And remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. These videos should be available to you to see again within the next few weeks. So be patient with us. Our next Zoom conference will be on Monday, February 8th at 1 p.m. Eastern Time with Dr. John Schaefer, whose topic is MS through the lifespan. So again, I thank all of you for participating, and especially Dr. Gyang. It's good to see you. Pleasure to meet you, and I hope to see you again soon. And thank you for sharing this information with us all today.
Thank you, everyone, and it was a great pleasure presenting to you all.